Hi everyone, I'm Dr. Hajira and today I'm going to talk about diabetes and its microvascular complications. Diabetes is a chronic metabolic disease characterized by high blood sugar, that is hyperglycemia, due to deficiency of insulin secretion by the pancreas or insulin resistance. And in the long term, this can lead to complications such as macrovascular complications due to involvement of the large arteries of the heart, brain, and limbs, leading to myocardial infarction, that's heart attacks, stroke, and peripheral arterial disease. And the other one is microvascular complication due to damage to the small blood vessels. If the blood vessels of the eye, that is the retina, is involved, we call it diabetic retinopathy, where there is progressive loss of vision leading on to blindness. And when it involves a kidney, we call it diabetic nephropathy or kidney disease, which leads on to end-stage renal disease. And when it involves the nerves, we call it the diabetic neuropathy. And here the complication is impotence, erectile dysfunction, and diabetic foot disease, leading to ulceration and lower limb amputation. So coming to the risk factors, diabetes by itself is a major risk factor. The longer the duration, increase the risk of microvascular complication, and also the increasing severity of hyperglycemia with high HbA1c, and those on insulin use and insulin resistance, they have an increased risk of microvascular complications. Other contributing factors is hypertension, dyslipidemia, obesity, smoking, alcohol, old age, and poor socioeconomic status, and there are quite many more factors which can increase the risk of microvascular disease. Coming to the pathophysiology, it is the high blood sugars, that is hyperglycemia, which leads to damage to the blood vessels and the nerves. This high blood sugar leads on to the production of free radicals, which leads to oxidative stress, inflammation, and production of advanced glycation end products. This leads to endothelial dysfunction, vascular permeability, and inflammatory changes. That leads to the leaks and the bleeds in diabetic retinopathy, leads to glomerular hyperinfiltration in the kidney, leading to chronic renal failure, and the demyelination and axonal loss in the nerves leads to neuropathy. So if we see how hyperglycemia can damage the nerves and blood vessels, it's very important to have early detection. So that is why screening is very important. The timing of the screening in type 1 diabetes, it is within 5 years of diagnosis. For type 2 diabetes, at the time of diagnosis, screening is very important because most of the time hyperglycemia goes undetected for a long time and it causes the damage even before diagnosis. And in pregnant ladies, preconception counseling is very important, and if they're pregnant, by the first trimester of pregnancy should be the first screening, and even in postpartum, it's important to follow up for up to 1 year because there can be progression of diabetic retinopathy. And now let's come to diabetic retinopathy. So what are the presentation? What are the signs and symptoms? Early on, there are minimal symptoms. Only in the advanced stage, there is vision impairment, blurring of vision, going on for blindness. So the screening methods that we have, the most important is to have an annual screening with comprehensive dilated retinal examination by ophthalmoscopy, fundus photography, then fluorescein IV angiography, and optical coherence imaging. And the treatment modalities, the most important is to have good metabolic control of the sugars, lipids, BP. And very important is early detection and screening. And there are 3 treatment modalities for diabetic retinopathy based on the findings. So the grading of diabetic retinopathy depends on the hemorrhages, the exudates, the edema, and the proliferation of new blood vessels. So there are the 3 treatment modalities is medical management with injections that is the intravitreal injections, that is injection into the eye with anti-VEGF agents or steroids. The other modality of treatment is laser with pan-retinal photocoagulation, and in case of severe hemorrhage into the vitreous chamber, vitrectomy is another treatment. Next we come to diabetic nephropathy. Diabetic nephropathy, here again the symptoms are very minimal early on, and in the advanced stage there can be, the first sign could be hypertension with protein loss in urine, edema, tiredness, and other signs of chronic renal failure. So the screening method here is very, very simple. It is by a spot urine test or a 24 hours urine test for albumin in the urine. And if there is an albumin excretion which is more than 30 milligrams per day, it is very significant, along with a glomerular filtration rate or GFR if it's less than 60 ml per minute, and this finding is persistent for 3 months, then it is suggestive of diabetic kidney disease, along with other renal function tests like creatinine clearance, urea, and the electrolytes. This is the diagnosis for diabetic kidney disease. Very important to remember, there can be transient albumin in the urine when a person has performed exercise, takes a diet rich in proteins, has urine infection, or high blood sugars. So this has to be kept in mind. And also, in case there is the diagnosis further on can be done with ultrasound of the kidney, and also renal biopsy, only done, not usually done to diagnose diabetic kidney disease, but it's done only to diagnose if there are other non-diabetic renal causes. And the treatment here is good metabolic control, that's very essential, and avoidance of nephrotoxic medications. And we have nephroprotective agents such as ACE inhibitors, ARBs, and for sugar control, SGLT2 and GLP-1 agonists have shown promising results. Now we come to diabetic neuropathy. Now diabetic neuropathy, the signs and symptoms are there early on. This depends on the nerves which are involved. The most common is the sensory nerve involvement. This is the distal symmetrical polyneuropathy. That is, the person can have stabbing, sharp, shock-like sensation and a lightning-like pain in the extremities, starting in the toes, going up to the legs and the hands in a glove and stocking pattern. Also, person can present with numbness and loss of sensation, which can lead on to ulcer and suggest the risk of amputations in the future. If the motor nerves are involved, it can lead on to wasting and weakness of the small muscles of the hands and feet. If the autonomic nerves are involved, and especially the cardiovascular system of the heart, there can be variation in the heart rate, and there can be postural hypertension. That is the BP, there's a drop in the blood pressure when the person changes position or in the standing position. And if the gastrointestinal tract is involved, there can be delayed emptying of the gastric contents. That's called gastroparesis, and enteropathy, which can lead on to diarrhea, constipation, and incontinence. If the genitourinary tract is involved, there can be bladder dysfunction with incontinence and recurrent urinary tract infections, and also erectile dysfunction, which is a debilitating complication. And also, if sometimes individual nerves can be involved, which is called mononeuropathy, when especially if the cranial nerves are involved, that is third, fourth, and sixth nerves which supply the eye muscles. If that is involved, then it leads on to drooping of the eyelids and diplopia, that is double vision. Sometimes the nerves of the hands are involved, which is the median nerve. It's called carpal tunnel syndrome, and ulnar nerve at the elbow, which is ulnar neuropathy, which leads to shock-like sensation in the hands. Sometimes the spinal nerves or the nerve root plexus are involved. So very simple method to screen for neuropathy is by a monofilament testing, which tests for light, touch, and pinprick, also check for thermal sensation, and by a 128 Hertz tuning fork, getting to know the position sense and the vibration sense. And most essential is foot examination, looking for ulcers, callus, blisters, and which can suggest that this person is going on for the risk of amputations. Treatment is again good metabolic control And for the pain control, we have analgesics, which are tricyclic antidepressants, gabapentin, alpha-lipoic acid, and capsaicin, and many more agents. Finally, maintain your ABC targets. That is the HbA1c less than or equal to 7%, blood pressure less than 130/80, LDL cholesterol less than 100, non-HDL cholesterol less than 130. Lifestyle recommendations: a diet restricted in carbohydrates, sodium and saturated fat, exercise, aerobic exercise around 150 minutes per week with resistance training 2 to 3 times per week, maintaining BMI less than 25, alcohol restriction, and smoking cessation. Finally, the key message is early detection and follow up with your diabetes care team. Stay safe, stay healthy. Thank you.